Disclosures, none relevant to the talk today. So most of this is based on guidelines. So I just wanted to go over guideline-based optimal medical management. And these are based on the 2012 guidelines with updates in 2014. And so this kind of covers both of them. And then obviously there have been since some more new guidelines, and I'll try to incorporate them as and when I can. There are a lot of slides, so I'm going to run through these. I'm not going to go over the strength of indication, because if not, we won't have time to finish this. These are the individuals who put together these guidelines. Some folks from here. Okay, the first thing, one of the key guideline messages is there are very few situations where revascularization actually makes an impact on mortality. Say left main, maybe triple vessel disease, maybe a proximal LAD with another vessel. Those are the few situations wherein you actually can claim mortality benefit for any of the revascularization at all. And even there, Cabbage was the one that shown in the early 70s, 80s. Dr. Ramchandani gives a very nice talk, you'll hear him later. But just remember one thing, Cabbage at that point of time, optimal medical therapy barely included anything. So things have moved since then. So at this point in time, it's very difficult to know, how any method of revascularization will do against optimal medical therapy. And the other thing is PCI has never obviously been shown to have mortality benefit in the setting of stable ischemic heart disease. Not talking about acute coronary syndrome, I'm not talking about an ST elevation MI. In stable ischemic heart disease, there's not any clear evidence of benefit. So your cornerstone of therapy, based on which you will be judged on your performance, is going to be optimal medical management. And that's what I hope to cover over the next 10 minutes or so. So among these, what you consider to be optimal medical therapy, you have several facets, and we'll go over most of these. The first thing that the newer guidelines, pretty much every guidelines across the board, is starting to make us do, or which we should have been doing, is to also get your partnership going on with your patient and educate them as to what's going on. So in this guideline, you'll actually see that there are several importance of an informed patient, and all of these have the highest grade of recommendations. Education of your patient, going over all the options that there are, an explanation of what medical management is and why you're doing one versus the other. All of these become critical parts of your initial interaction with your patient. Description of appropriate levels of exercise, goals for therapy, all of these are also important. What's your weight? What's an ideal weight? How should you get there? What is an ideal physical activity? So as a cardiologist, when you're seeing your patient in your clinic, these are all discussions that you should have on a routine basis to try to inform them as to where they should go. Now, if you look at the actual medical therapy itself, beyond your patient interaction and things, this comes in the whole, management. But if you look at therapy, let's go over lipid management first. Now, a few years ago, it used to be LDL cholesterol less than 100 and less than 70 if you were, high risk, et cetera, et cetera. Now, with the recent lipid guidelines, these are changed. But if you look at even these guidelines, what they say over here is, other than physical activity and diet, which, are initial cornerstones of every therapy and every risk modification, and here we'll go over physical activity in a little bit more detail later on. What they say is moderate or high dose statin. Even in these guidelines, they call moderate or high dose statin. So what is moderate and high intensity statin? For all practical purposes right now, high intensity statin, only two are available in the market. That's atorvastatin 40 to 80 milligrams or rosuvastatin 20 to 40 milligrams. So you'll have those, and that's basically what your high intensity statin would be. Moderate intensity statin would be the lesser doses of those, and several others, including simvastatin and things like that. Now just remember, simvastatin 80 milligrams is no longer an approved dose for you to use. So because of the side effect profile of it, do not use simvastatin or start simvastatin 80 milligrams. So most often you're going to get with atorvastatin, in your patients with ischemic heart disease, atorvastatin or rosuvastatin at the high intensity statin. So if you actually look at what the guidelines, the new lipid guidelines say, what you'll notice is if you're age greater than 21 and you have clinical atherosclerotic cardiovascular disease, this includes any vessel with stenosis greater than 50%, cerebrovascular, peripheral, whatever it is. Okay, all of these come under the same atherosclerotic clinical cardiovascular disease. Then you go for statin therapy. If your age is less than 75, you will go into high intensity statin therapy. And all of what we're saying is provided you have no contraindications and provided your patient is able to tolerate it. Age greater than 75, you have a slightly higher risk of statin-mediated side effects. So there, perhaps you can start at a moderate intensity statin and work your way up if you need. So although there are no goals, you should still continue monitoring lipids. And one of the things, cornerstones is what you expect is about a 50% reduction in LDL cholesterol. That's what you're shooting for. Sometimes you get asked the question, what happens if your LDL cholesterol is 75 or 80? Guess what? 50% of that still gets you only down to 40. Okay? Several of these studies have shown that people at even lower cholesterol seem to do okay. So what the guidelines tell you is if your LDL cholesterol is less than 40 on 2 consecutive occasions, maybe you cut the dose down. But the message I'm trying to communicate here is do not fear starting a higher dose of statin because your LDL is 95 or 100. You're not going to get it down to 0. Okay? You will have enough LDL cholesterol most likely to function. Okay. As far as the blood pressure management itself goes, here you follow the JNC guidelines. You have a newer JNC version of it, JNC 8, that is available at this point in time. There they've relaxed the measures as far as what the blood pressure goals are. For older individuals, they say you can relax up to 150 over 90. But most times in CHD, when you have diabetes and all that, you're trying to shoot for that 140 over 90 or lesser than that. Now, previously they used to have more aggressive targets for diabetics and CKD. They kind of backed off that a little bit because of the side effects associated with treatment. The corollary to this is if you have a patient and he's tolerating 120 over 80, you do not have to back off the medications. You can let him or her be there. But on the other hand, if they have symptoms, you have a little bit more leeway to work on it. Now, the actual guideline recommendations you can see here. Lifestyle modification is important. Weight loss and actual diet, a good DASH kind of diet, is almost equivalent to 2 medications. You can get up to 10 to 20 millimeters of mercury reduction, while an average medication gives you about 10 millimeters of mercury reduction. So this has to be a cornerstone of your therapy. Other than that, in individuals with ischemic heart disease, like we talked about, 140 over 90. With diabetes, the main thing to remember is there is no clear-cut evidence that diabetic control or hemoglobin A1C control is going to improve your cardiovascular outcomes. You do it for other microvascular conditions. And because of this is where the guidelines now state that less than 7 is reasonable, but in some individuals who can't tolerate it, 7 to 9 is also acceptable. Okay? So these are the things that you have to remember as far as that goes. Medical therapy to get these individuals over there is reasonable. The only thing is do not initiate rosiglitazone. As you can see there, it's a class 3, should not be initiated in individuals with coronary heart disease. As far as antiplatelet therapy, I'm not going to go into the newer antiplatelet therapy that's more of the post-PCI kind of arena, but in the setting of stable ischemic heart disease, aspirin is as good as there is, 75 to 162. In individuals who are not able to tolerate aspirin, clopidogrel is a reasonable alternative. And in select individuals who you view as higher risk, maybe they've had multiple revascularization, maybe they keep having angina on top of that and things like that, you could consider the combination of aspirin and clopidogrel, provided their risk of bleeding does not outweigh the potential benefit to be had in those individuals. Dipyridamole, you guys probably don't even know what it is. Anyway, it's not used, so there you go. As far as beta blocker therapy, now clearly we know heart failure and use of beta blocker and heart failure, indications. But in your individual who's had an acute coronary syndrome or an MI, even in the setting of normal LV function, what is recommended is up to 3 years worth of beta blocker therapy after having that event. Okay. Now, in EFs less than 40%, clearly you use it for the heart failure management point of view. There you would want to use the ones that are specific towards heart failure, carvedilol, the longer-acting metoprolol, bisoprolol. These are the ones that have been well studied in them. You want to try to avoid the tartrate if you can in that situation. If you need it for blood pressure, obviously you are going to use it as far as the beta blockers go. Now, the ACE inhibitors, same thing, EF less than 40%, CKD, diabetes, you want to use it unless contraindicated. If you're not able to tolerate ACE inhibitors, ARBs are a reasonable alternative or a good alternative. Try not to use the combination of the both because your risk increases, so you try to avoid the combination of the both at this point in time. In individuals with CHD, it's reasonable to consider ACE inhibitors if you do not have, depressed ejection fraction also. In individuals with any kind of vascular disease, it's reasonable to consider based on the HOPE data and all of that. But again, there the evidence is not as strong as, say, if you had a reduced ejection fraction, but it's reasonable to use in those individuals. Now, smoking cessation is something we all know. We all, tell our patients you shouldn't smoke. But truly what the guidelines recommend and truly what we should be doing is actually assisting your patient in trying to go through this, okay? Now, it's the highest class of recommendations because of what smoking can do to you. And they go through this, strategy of ask, advise, assess, assist, arrange, and avoid, or the A's, how many ever A's there are, 6, I guess. So, just for you to be able to, now, the reason why I point this out is these are part of your performance metrics. Are you actually counseling a patient? Are you congratulating a patient who's quit smoking? Are you actually giving them alternatives of how they're going to quit smoking? These are all part of what your documentation should include and part of what you should be doing. Okay, so there is a nice algorithm that's available in the thing, but basically goes through those five, six A's that we talked about. But essentially, it goes over the same thing about asking, assisting, and then seeing who's ready to quit. If they're ready to quit, you give them the potential the tools that are needed. Now, this is an important thing. Setting a quit date, announcing to their family and family members, because they are going to be grumpy when they quit smoking, so letting them know. And then avoiding all tobacco and paraphernalia that they may have there, and keeping themselves busy. Advise your patient that they're probably going to gain weight, because something needs to go into that mouth, and something else is probably going to be food, so they are going to gain weight. So you want to tell them that so that they are aware of all of these things. If not, they will, they just get dejected and stop trying. So you should be a facilitator of that, and you should know what your local resources are for helping smoking cessation if you don't want to do it yourself. Now, as far as physical activity goes, at least 5 days, preferably 7 days, 30 to 60 minutes. The goal is to try to move people out of this least fit and least active group, the bottom 20th percentile of the group, and try to, and the other thing people always tell you, I'm always, I'm busy at work, I do a lot of work at thing. So my general thing to that is you are where you are despite what you do. So the thing is you have to move it further. If not, you're not going to get better. You are, wherever you are, you've done all that you can to get over there, right? So you have to try to add to that, and that's what you have to try to let your patients know. Cardiac rehabs are important. These are, in individuals with CHD, and you should, again, know what your resources are available as far as that goes. As far as weight management goes, you should advise them what an ideal body weight is. Again, your BMI between 18 and 25. There are limitations with BMI. For example, if you take Schwarzenegger or Sylvester Stallone, their BMI is greater than 30, but they're fit. So, you want to be aware of those kinks. But in general, BMI is a good surrogate, and that's what we use in our clinical management as far as what should be thing. Now, the other thing is, the important thing to stress to your patient is their ideal body weight may be 100 pounds of what they are right now. But even the 5 to 10% initial reduction, which may be as low as 20 pounds or 15 pounds, will get them already far ahead as far as reversing their metabolic parameters and things like that. So this is something you have to tell your patients, because if you tell them all you have to do is lose 10 to 15 pounds, it's a lot more easier for them to say, okay, I can do that, rather than say you have to lose 80 pounds to get your ideal body weight. You already give up before you start. So this 5 to 10% body weight loss has been shown in several studies to improve all your risk factors, and that's your initial goal. If you're able to achieve that, go ahead and build on that success, but at least start there. Now, as far as relief of symptoms goes, anti-ischemic, beta blockers will be the first line, then the calcium channel blockers and long-acting nitrates. In individuals who have chest pain, immediate relief will be sublingual nitroglycerin. That's what you would recommend. And then after that, treating with longer-acting non-dihydropyridine calcium channel blockers. Ranolazine, remember, is useful initially as a substitute for beta blocker, but it can be used in combination with a beta blocker also, but initially you try to use it as a substitute. These are your anti-anginal arsenal that you have. There have been a wealth of evidence showing about how people with coronary artery disease tend to be depressed. So depression screening is now in our guidelines as part of what we should do. And treatment is reasonable, although we don't know if it's going to impact your outcomes or not. But that's something to consider. As far as alcohol consumption goes, what is okay? About 1 drink for a woman and 1 to 2 for men are considered reasonable on a daily basis. Anything more is where you want to have them draw a line and have them not. And all of these, again, I'm telling you, are making sure there are no contraindications. You don't want that for a cirrhotic, but in general, if everything else being equal. Avoiding exposure to air pollution. Air pollution has, again, been associated with events. So this is something to just educate your patient. These are all part of the guidelines. That's why I just bring it up there. Flu vaccination and avoiding, how do people with flu die? Other than ARDS, it's MIs. So, trying to have your individual vaccinated with flu, part of what we should be doing on a regular basis when we see our individuals in clinic. As far as additional therapy to reduce the risk of MI and death, there are a few things that have been investigated. Chelation is now one of those things in which we're not sure. There was one study that said maybe benefit, some that have said no. So here they say that it is unclear as far as reducing events go, so they don't say one way or the other. The other things, estrogen therapy, vitamin C, vitamin E, treatment of elevated homocysteine with vitamin B12, garlic, coenzyme Q10, selenium, chromium, everything that your patient might come in from your local over-the-counter medications, none of them have shown any benefit. So those are things that we have a class 3 saying that we don't think we need it for treatment of ischemic heart disease. Chelation, we're not sure. There are bigger trials going on right now. So right now, we can't advise them one way or the other. So if you look at an algorithmic form, essentially, for the sake of time, this is what we covered right now. So I'm going to move on to the last thing, but essentially goes over all the medications and things that you have to go in those individuals. Finally, alternative therapy for individuals with refractory angina despite all of this. External counterpulsation, some individuals have had some benefit with that. It's a 2B. Spinal cord stimulation, again, a 2B. Some possible relief. Acupuncture, no. Transmyocardial revascularization with laser, sometimes there's some benefit. So these are all things that have been suggested. The bottom line is, remember all the basic risk factors and control of them, the guidelines as far as that goes. But remember these other things that you as a cardiologist should be doing, including screening for depression, smoking cessation, flu vaccination, all that. That I'll stop. Thank you.
Thank you, Vijay.